It's a pleasure to be with all of you today. I stand here as a representative of your Louisiana Blue Cross plan and want to spend some time with you today telling you a little bit about what's going on in the marketplace right now and to give us a feel for what changes we expect that are on the horizon and to give you plenty of time to ask me questions before we're done. So let's take a look at the Louisiana population today. We have a little over 4.6 million people in the state right now. About 1.6 million of those are walking around with a Blue Cross card in their pocket, either from the Louisiana plan or from a different Blue plan in another state. Last time I checked, we had about the same number of people in Medicaid here in Louisiana and about 700,000 people in the Medicare programs, and another 600,000 or 700,000 in other private insurance plans around the state. And fortunately today, our uninsured population is significantly lower than it was 8 or 10 years ago. So that's progress. That's moving to the good right now. The biggest challenges that we face on a day-to-day basis are the cost of healthcare. Our job as an aggregator for our members is to make sure that we have the money in place to pay for the healthcare they need and the healthcare that they, in many cases, would not be able to pay for themselves, as the price of healthcare has gone up pretty quickly over the last 10 or 15 years. We've tried really hard to be a bulwark against that, to help the Blue Cross population really survive what's coming next. Our mission, and we talk about this every day when we're with our friends and neighbors in the population here in Louisiana, is to improve the health and life of Louisianians, not to improve the health and life of just Blue Cross's population. We do a lot of community outreach, and we want to make sure that our reach extends far beyond the people who do business with Blue Cross. It's a challenging situation in Louisiana right now. We have what I call the triangle of problems that we deal with on a day-to-day basis. Louisiana is ranked very near the bottom in rates of tobacco use, rates of diabetes, rates of obesity, all things that shorten lives and lead to significant healthcare problems as we move forward. Last time I checked, our rate of tobacco use in Louisiana was 22%, maybe a little higher than that. Compare that to a state like California, where you find the tobacco use rate is around 11%. That's a big difference and drives a lot of healthcare spending here in the state. We have a significant portion of our population now that is either diabetic or on the road to diabetes. And one of the things that's not always clear to folks is that type 1 diabetics tend to be born with a problem where they can't produce enough insulin. Type 2 diabetics tend to kind of give it to themselves over time with lifestyle and with choices that we make. I can tell you personally, 10 years ago, my doctor looked me in the eye and said, "You're on the road to diabetes. What are you going to do about it?" And I said, "I don't know. What do I do?" You know, and my doctor was very nice. He said, "Mike, it's not complicated, okay? You need to lose weight. You need to control your blood pressure, and you need to make sure that you make healthier choices in your diet. And you need to move more. You need to get out of your chair. I know you're a guy who works at a desk all day, but you've got to figure out a way to get up and move around. And you've got to take this medication every single day that will stop you from becoming insulin resistant, or at least slow down that process." And so 10 years now, it's been a battle, but my blood sugar is completely stable. Recently, I went through a program at work where I lost 10% of my body weight in about 3 months, 4 months. And that actually pushed me, it reduced my chances of developing diabetes by 50%. Just that one program, just losing 10% of my body weight. So these are the kind of messages we'd really like to get out into the population. It's about blood pressure control, tobacco use, blood sugar problems. And another statistic we lead the nation, and we don't talk about very often, is the fact that we lead the nation in kidney disease. And over 80% of the kidney disease in the marketplace is caused by people who have out of control blood sugar and high blood pressure at the same time. It turns out that those two factors are just deadly to the blood vessels in your kidneys and things that make them go. And so in Louisiana, we have a very high percentage of the population that has high blood sugar and high blood pressure at the same time, often undiagnosed. And that leads to kidney failure and a large population on dialysis or on transplant list. All of this stuff is bad for us. It all costs a lot of money. I noticed recently that in Louisiana, we had in the neighborhood of 500,000 people that are full-blown diabetics today. 500,000 of our friends and neighbors, and another 1 million that are what's called pre-diabetic, which means their blood sugar is creeping up steadily year after year. They're on the train, the expressway, to diabetes as well. Nationwide last year, we spent $300 billion with a B on diabetes care. So I thought to myself, being an economist, what was the opportunity cost of that? What could we have done with $300 billion if we hadn't spent it on diabetic care? And one of the things I noticed was that we could have built a lot of interstate with it. In fact, we could have built 50,000 miles of interstate, enough to go back and forth from New York to San Diego 20 or 30 times, right? If you gave the Navy $300 billion and said, I know you guys want a bigger Navy because you're stretched very thin, how many ships could you build in a year if I gave you $300 billion? How about 20 aircraft carriers? Now, we only have 10 today, and 1 or 2 of them's always under repair, but they could build 20 more, planes and all, for what we spent on diabetes care. I mean, these are simple examples, but it's a huge amount of money, and it's a national plague. At Blue Cross, I can tell you that we do everything we can think of to help folks manage their diabetes. A lot of the plans that we have, their diabetes control drugs, have very low or no copays. We have disease management folks, nurses that talk to them on the phone all the time and give them guidance, free nutritionist visits. There are a lot of benefits that we have that are specifically designed to help people who are on the diabetic train stop where they are and go backwards, or the people who are already diabetic control their conditions. So I feel like I'm harping on diabetes too much, but I can't express to you what a problem it is for us going forward. To make matters worse, the price of insulin that diabetics use to control their blood sugar has gone up 350% in 15 years. 350%. Now, remember, the guys who invented insulin were some docs in Canada, and they sold the patent for insulin to the University of Toronto for $1 because they wanted the whole world to benefit from what they had discovered. Now, it's not unusual for a diabetic on insulin to spend $1,500 or $2,000 a month on insulin. So, I mean, these are the kind of things we look forward and we say, if we're going to manage healthcare costs, how do we intervene? How do we make sure that people have the tools that they need to stop this in its tracks? So those are important things to me right now. On a local level, I feel like that we have an individual marketplace. You know, we sell group insurance in Louisiana. About 90% of the people in the state who have a private insurance plan have it because they have a job or they're related to someone who has a job. It comes through their employer. About 10% of the people who are privately insured in Louisiana have an individual insurance plan. About half of those people get those plans through the Affordable Care Act exchange, healthcare.gov. But about half of the people with individual policies got them in the marketplace without any federal assistance, and their rates have almost tripled, have doubled rather, in the last 5 years. So intervening in the individual market right now is huge. In 2013, there were 15 carriers selling individual products in Louisiana. Today there are 2, Blue Cross and Vantage, and that's it. So I kind of felt like we missed an opportunity at the legislature in this last session when House Bill 472 went down and didn't get out of the Senate and wasn't referred favorably. The idea there was to put an assessment about $1.25 or less on every insured life every month in Louisiana and use that to create a pool of money that could then be used to draw down matching funds of $3 or $4 to the dollar raised. And then that money could be used to defray the cost of the sickest among us, the people who are the neediest among us, who have individual coverage, so that insurance plans could keep those people inside their health plan, but not have double-digit rate increases every time. And unfortunately, we weren't able to get that through successfully this time around. So with that, I'm going to take a break here and let you know that as an economist at Blue Cross, it's always delightful to me. I enjoy so much being out in the world, and I have a huge family. My family's been in Louisiana for 300 years. So everybody knows who I am, and they all know I work for Blue Cross. And everywhere I go, they stop me and they, Mike, what about this claim and what happened here? And I really enjoy that. I know some people are a little nervous about it, but I kind of like being part of the community and being able to tell people this is how your money is being spent. This is where it's going. And that transparency is huge. And I think it's something that we really need to encourage going forward. And I'm going to stop here and take your questions if you have some for me. Yes, sir.
Let me make sure I understand you correctly. There are only two private insurers now, like an individual just wants to buy, get their own insurance. They can go to Blue Cross or Advantage. Is that correct?
Yes, that's correct. Yeah. Okay. That's great. The question was, is it correct that there are only two private companies selling individual health insurance in the state of Louisiana today? And the answer to that is yes. If you go on healthcare.gov on the Federal Exchange website, then you can see which plans are available in a market like Baton Rouge. You can buy a Vantage healthcare plan or you can buy a Blue Cross plan, and that's it. There are no other carriers who are selling individual today. And I believe the second part of your question is, did that have something to do from the Affordable Care Act? Well, there's no doubt that the ACA has completely reshaped the individual market. The individual health insurance market used to be regulated on a state level, state by state. But when the ACA passed in 2010, the individual market was federalized. They basically said, we want to create a uniform individual set of standards, basic standards, that would apply from coast to coast. So in the writing of the ACA, the authors pulled that authority back to DC. And they said, here are the basic standards every plan is going to have to follow. One of the criteria they laid on top of that was what's called a guarantee issue provision, which means that you have to be admitted into an ACA plan without any regard to your health status, what drugs you're on, or any pre-existing health condition. And if you're going to do that, you have to build a marketplace that has very clear boundaries around it to make sure enough people show up, to make sure that that insurance risk pool is stable and self-sustained. Unfortunately, there were some bad policy decisions made in the original ACA that have made it very difficult to sustain that risk pool. And for example, in the first 3 years of the ACA, Blue Cross, we lost just in Louisiana over $200 million just on the individual market. The main reason that happened was we didn't raise rates fast enough to keep up with the claims of the people who showed up to buy individual coverage. Their health status and conditions were much worse than we expected. And so we've been playing catch up ever since. Does that help? Yep. Yes, sir.
The state of Louisiana in the past has been found to do some shenanigans of pulling dollars and then matching federal funds with it, and then later on finding out that that was really an improper methodology. Do you think that concern impacted your bill in the legislature, or do you think there are other factors that impact it?
Well, the question was, did I think that previous history with matching funds, shenanigans as you called it, might have made it harder to get the waiver and the high-risk pool we were just trying to get through HB 472 done? I think that this process is a little different from what you've seen in the past, because you had to create a Section 1332 waiver that went directly to CMS, and they had to approve how the money was collected and how it was spent. And so there's a lot more guidance in the 1332 waivers than I think some of the programs we've seen in the past. So I can tell you personally, I didn't think that was a fear that we had to overcome. I didn't hear too much resistance on that note.
I have a question about late enrollment fee.
Yes. A question about late enrollment fees, yes.
What's the rationale behind it?
Well, late enrollment fees mostly apply, I assume you're talking about Medicare, right? When you turn 65, you're supposed to enroll in Medicare. If you wait, they charge you a higher premium because you waited. The rationale, I believe, is, and I'm not an expert by any stretch of the imagination, but when you're trying to build a stable risk pool of individuals that's funded and stays solvent, it's important to get everybody into the pool as soon as possible. The last thing you would want is seniors waiting until after they got sick or got a significant health condition to jump into a Medicare pool where they've already funded it basically by having payroll deduction their whole life. Every day we work, they take 7.5% or 1.5% rather out of your paycheck for Medicare and Medicaid. After you turn 65, you have the option of enrolling in Part A and B right away in Part D. And so they want to nudge people, I believe, at the federal level to enroll as soon as possible.
I have a follow-up question.
Okay.
The reason why I'm asking, because some people, they did not join the drug plan because the costs were minimal. And so they got penalized for trying to save money for not buying into the drug plan.
Okay.
So is that
So the comment was that because some people waited to join a Part D plan because they had no drug need at that time, they wanted to save money, so they didn't enroll until they were older, and then they enrolled in Part D, and they were penalized for that. And you want to know why? Yeah, I don't know. It's a good question, but I'm going to defer to the guys who wrote the Part D program because that's one of those bills that was written about 15 years ago now, almost 15 years ago since we did Part D. And I don't think too many of the guys who wrote it originally are still in Congress. So it would be tricky for me to kind of read their mind. Yeah, go ahead, Sam.
Given the failure of the reinsurance proposal,
Yes.
are there any alternatives that y'all are getting behind? Do we have to wait until the next legislative session to try to bring that one back up again? And also, given the fact that y'all made money in the individual exchange this year, could you address what that means for the market moving forward?
Absolutely. So Sam's questions were, if I've got it right, since HB 472 didn't make it out of the legislature this time around, are there any other programs or things we're looking at to help defer that cost? And the second question was, since we made money this year, how's that going to reflect on our efforts going forward next year, the year after? Great questions. Let me start with the loss of 472 is still very fresh. And we haven't really assimilated everything that's happened or studied it so far to understand, why it didn't go through. So I think we need a little more time before I can answer your first question. We're still kind of in that phase where we're doing, what would you call it, a post-mortem on the bill, trying to understand exactly what happened and what the opportunities are going forward. You talked about we made money in 2017. Almost all of the money, 75% of the margin, the profit that we showed in 2017 was a result of a very late decision by President Obama, actually, right before he left office, to eliminate the health insurer tax that we were having to pay for the year of 2017. So in other words, a federal obligation that had been on us since 2014, nationally, that obligation was over $14 billion. So if you hear a lot of media about, insurance companies are doing much better, you got to factor in the fact that a $14 billion tax was waived for 1 year, for 17. We have to pay that tax again this year, and 19 is kind of up in the air right now, okay? So that was unexpected. We still had the tax built into rates, but the tax wasn't collected, so we can roll it forward to this year and hopefully use it to pay this year's taxes. That's kind of where we are right now. Yes, sir.
Yeah, Mike, a couple of questions. One is when you speak to the increased cost of doing business, how much of that increase is due to changes to Obamacare that have been instituted by the Trump administration?
Okay. The question was, when I spoke of rate increases or more costs in the system, how much of that was instituted by the Trump administration? Did I get that right? Okay. Let me start off by saying it's too early for me to tell what the changes that have happened during 2017 to the healthcare bill are going to do to rates. There are a lot of estimates in the marketplace. I don't agree with a lot of them. One of the estimates, for example, is that there's no more individual mandates starting next year, where there's not going to be a penalty where you have to pay if you don't buy insurance starting in 2019. And by the way, let me point out that has not started yet. I get emails all the time from people who think they don't have to pay the fine for their 18 taxes or their 17 taxes. That waiver of the fine does not begin until 1/1 of 19. The rationale behind that being a driver of rates is that younger and healthier folks will leave the ACA marketplaces, and so you'll be left with an older and sicker population. It sounds perfectly rational, except the individual mandate that's being waived has 29 individual exemptions to it. And the good tax guys out there know what all 29 exemptions are. And so when I take a look at our ACA population, if you look on healthcare.gov today, we have probably 80,000 members that are buying insurance from us on healthcare.gov. The average age in that pool should be about 35 years old today. With the fines and the penalties, it's not. It's 46 and rising. The young and the healthy in that pool are already, most of them have already left by November in each year. The ACA kind of created this process where we have an open enrollment period that ends in January. And people enroll and they sign up. And at the beginning of the year, we have about 85 or 90,000 people every year. By December, we're down to 60,000. And almost all of the people who left during the year are under 35. And the reason they left is almost entirely they're healthy and the price is too high. They can't afford it and they feel fine, so they pay for a while and then they walk out. Okay, they're already leaving. I don't believe that you're going to see a dramatic rate increase in Louisiana because of the individual mandate penalty going away. There will be some effect, no doubt about it, but I'm not as worried as some of the other pundits I've talked to are about that. So,
A second question.
yes,
This might be a softball.
I take it. I'm not opposed to softballs.
What is Blue Cross doing to actually help the poor get insurance?
Helping for the poor to get insurance. Okay. Most of the efforts that we have in the marketplace are focused on community health. We are strongly supporting right now our foundation. The Blue Cross has a foundation that goes into communities and tries to establish grant programs to drill through some of the social determinants of health that are holding people back. So for example, a couple years ago, we ran a contest of who could do the best urban gardens and food programs, because we knew we have a lot of urban poor in Louisiana who live in food deserts. There's no grocery store close by. They're buying their daily bread at the bodega, or they're buying from McDonald's or buying from somewhere else. And so they don't have access to fresh fruit and vegetables. You can't really expect them to correct their diet if they can't get to the food they need. And so we had companies come to us who started food trucks where they were bringing fresh produce into underserved areas. And we funded that. And we wanted to make sure that they had the opportunity to pull down grants to make that go.
That's not insurance.
It's not insurance, no, not at all.
So again, what is Blue Cross doing to help the poor and underserved get access to health insurance?
Get access to health insurance, okay.
Their policy.
Yeah, well, I can tell you that one of the things that we do that most carriers don't is we support a broad network of agents who have the ability to help people enroll in insurance and get advice for free. Cost them nothing. They find out everything they need to know about private insurance, but they'll also refer them for Medicaid enrollment if their income qualifies for that. So it's outreach, and it's going on all the time. They can come to Blue Cross's building, and we have agents right there in the lobby that can help. But there are networks of private individual agents scattered around the state who deal with these problems every day. In many states, these agents have been cut off from commission. They're not making any money, or they've left the marketplace. We have maintained a payment structure at least strong enough and given them support so that they can stay afloat in every city in Louisiana. So that network of people is out there today, and you can find them on the internet, on our website. There's always a button you can push, contact an agent, and they can help you to understand exactly what your options are, no matter what your income level is. Also, I can tell you, I'm a big supporter. I don't know if you guys know Brian Burton, that is kind of the coordinator for the Navigator programs here in the state. Brian is a really good friend, and he is the hardest working person you'll ever meet. And those navigators are underfunded, and they don't have any of the resources they need. And I have made it a personal point, to anytime Brian calls, to pick up the phone, to go out, to talk to people, to raise awareness, to do whatever it takes to make sure people know that they have health care options. And that's pretty much my whole job nowadays. Go ahead. What'd you say, Jim?
On the poor people and insurance access, I heard a state lawmaker, prominent one, in the last few days say that 40% of the people in Louisiana were on Medicaid, and that there were people earning over $100,000 a year in Louisiana who were receiving Medicaid. What are your numbers look like?
Well, the last time I checked, the new Medicaid population, we just expanded our definition of who was Medicaid eligible in the summer of 2016. And I can tell you the largest estimates during the Jindal administration, when they were taking a look at that, was that 260,000 people would enroll if they expanded the population. It's almost 500,000 now. It's 480,000 people in the new expanded Medicaid population. And that is good news, because those folks, many of them, have never had health insurance in their life. So they're getting their blood pressure checked and their blood sugar screened, and they're having doctor visits outside of an emergency room for the first time maybe in their entire life. So it's going to change the culture. It takes time. You've got to educate people on the proper way to access health care. But once Medicaid is embedded in the population and they start realizing that there are federally qualified health centers out there who will help them, there are primary care docs who can help them, I think we'll see a large expansion in the spread of knowledge about how to stay healthy and how to stay out of the hospital. Those are important things.
Threshold to get on Medicaid is what, 100?
Yes, 138% of the federal poverty line is the threshold for Medicaid for a single person. That's a little under $17,000 a year. For a family of four, it's about $34,000 a year.
And of the nearly 500,000 who have taken advantage of the Medicaid expansion,
Yeah.
that's in addition to people who were already Medicaid recipients, correct?
Yes.
So what is the total number?
I believe the last time, I don't know today's number, but the last time I looked, it was about 1.4 to 1.5 million total on
That would
Medicaid.
be more like 30%.
Yeah, my numbers show that if you add up the people on government plans today, Medicare plus Medicaid in Louisiana has just gone over 50%. But that includes the seniors on Medicare and the Medicaid
You're
population.
saying more than half of people in Louisiana are either recipients of Medicare or Medicaid?
Yes, that's the last number I got. It was right at just a hair over 50%. Yes, sir.
I have a question. Relating back to your earlier explanation of the program that you went through that helped improve your health, as an economist looking at the program that we currently have, with private health care through employers, the Affordable Care Act that brought hundreds of thousands on board, and then the Medicaid that was traditional, will this not effectively improve the health outcomes for the majority of the people in the state of Louisiana under the current program, the Affordable Care Act?
Oh, there's no doubt that the health of the state will improve because of the access to health care and Medicaid. Totally agree. Yeah, Lanny, did you have a question?
Well, of course, Congress is very closely balanced nowadays. People want to sack the ACA, and the burgeoning argument on the left that there needs to be some sort of public option or national health insurance. Is there some flaw in the system, the notion that Medicare for all might not be the path toward that kind of policy, because Medicare was not initially designed as a national health insurance a la Canada or Britain or the other industrial countries?
So the question is a public option, or perhaps Medicare for all, something that's viable or that is needed in the marketplace today? My personal belief is that under Medicare today, we have to be as clear as we can about the limitations. People tend to think Medicare is great coverage, and it is. It's good coverage. But do you realize that if I took Medicare Part A and B and made an insurance policy out of it, it would be illegal for me to sell under the ACA?
Yeah.
Couldn't sell it. Medicare Part B has a 20% coinsurance with no cap. So there's no max out of pocket on Medicare Part B. If you buy private insurance as a single, you have a max out of pocket every year of $7,000 or $8,000. Medicare has no max out of pocket. So if you don't buy a private insurance add-on to your Medicare, you're financially exposed to the last dollar you spend. So for Medicare to become a public option that's viable, they've got to do a lot of work to it. They've got to create something that is more of a wraparound package than Medicare as it exists today, or you would leave those consumers with nowhere near the protection they'd have with Medicaid. They'd maybe have a few more doctors they could see, but they would have a situation where financially they would be more exposed. So I'm not saying it's not doable. I'm just saying the notion that you could just take Medicare and slap it over here on this private population without significantly increasing the cost, I think is misguided. Yeah. Yes?
Blue Cross has its HMO, I think it's Advantage programs for Medicare.
Yes, we have Medicare Advantage in 30 parishes now? 30? Yeah.
So many people take advantage of that. There are additional services such as health care programs and health exercise programs, et cetera, that are beyond Medicare, the basic Medicare. Blue Cross handles that. That's part of Blue Cross's product line.
Okay.
So if one were to talk about expanding Medicare to the general population, one might instead, as an economist discussed, expanding an Advantage plan to the general population, which you and I happen to understand that has an A/B that most people don't see, but still, if you expanded Medicare and Blue Cross were taking the Advantage plan, could you discuss that in terms of a solution to leave it privatized but still have someone paying?
Right. So the question is, can we talk about, instead of just straight government issue Medicare as Medicare for all, what about expanding Medicare Advantage as a product into the private sector? The basis of Medicare Advantage is a capitated payment, a flat amount of money that goes to a carrier, and they assume the risk of all of the health conditions of that particular individual. And over 65, or standard Medicare nowadays, that payment is substantial. It's about double what insurance costs at the private level now. So again, the barrier becomes, where are you going to get another 100 billion, 200 billion, 300 billion to extend this ostensibly pretty rich coverage back into the private sector? You might want to consider that, let's say I have a Medicaid population that's using services today, and I'm paying for their services. If I move them into a Medicare payment scheme where docs get paid at the Medicare level, their costs are going to go up 25 or 30%. Because Medicaid pays substantially below what Medicare pays for the exact same care, and private insurance has to pay more than what Medicare pays. In a way, we have three different levels of payment all coexisting in the system. And on the provider side, they have to figure out, how do I pay my bills when 40% of my bed days are Medicaid patients who pay this much, and 20% are Medicare and they pay this much, and then I've got a private insurance guy who's paying a little more. It's a real battle. And so I guess my caution is, none of these things are going to be simple. I think the real attraction for Medicare for all is, let's just make it simple. It will not. It will be anything but simple, in my opinion. Yes?
Why do you think the ACA caught so many insurance companies flat-footed to the point that there were 50, now there are 2? And really, weren't they just trying to kill off the ACA by withdrawing from all these markets?
Okay, so the question was, why do I think insurance companies were caught so flat-footed by the passage of the ACA? And did I think that they were just withdrawing from the markets to try to make the ACA go away? Was that the question? Well, let me answer your first question first. Most insurance companies that got caught by surprise by the ACA were surprised because they didn't have me working for them, okay? Because in 2009 and 2010, I spent an awful lot of time in DC with the Blue Cross Association's lobbying group, talking to congressional staffers and Max Baucus's folks and watching the bills being developed. By the time the bill passed, I promise you the people at Blue Cross and Blue Shield of Louisiana knew what was going to happen, okay? That wasn't the problem. The problem was we had to make an estimate, sort of in the blind, of how much health care people were going to use that had never had health insurance before. And so I'm an economist, I build forecasting models. So we're modeling this with the actuarial team, and one of them suggested, they said, well, we've got another population of people, a proxy population that's very similar, and that's the small group market in Louisiana, because these small group folks, they have guarantee issue coverage, they can get insurance no matter what their health conditions are, and we've got years of history on them. Let's use them as a proxy, and we'll set our rates based on that. And we even built in a little fudge factor, another 20% on top of that. Right? In 2014, the population we attracted into the ACA used 80% more care than we estimated. And you can blame me for that, okay? Because I was on the team. Now, if I had had a time machine and I had gone back in time and said, they're going to be 80% more, I'd have probably got fired. But that was the reality. And from that point on, when that happened, carriers, not just Blue Cross Louisiana, but other carriers said, how do we ever make money in that market if that population has got those extensive health conditions? And that's essentially been the game since 2014, is trying to get rates high enough to cover it. Of course, every time you raise rates, the healthier and the younger of the population who aren't subsidized by federal assistance will walk out. And so your overall risk pool can get sicker and sicker. One of the things that's really contributed to this is they originally set the ACA up with an age rating ratio that doesn't match reality. Let me tell you what that means. So for example, in the ACA, the rule says that if I have a 21-year-old and a 64-year-old, and those are the limits of the adult population in the ACA, at 21 you're an adult, at 64 that's as old as you can be. When you're 65, you can't buy insurance on the ACA anymore. So the 21-year-old can only, the 64-year-old can only be charged 3 times as much as the 21-year-old, and that's in the statute, all right? Well, it turns out when we look at our data, 64-year-olds use 6 times as much health care as 21-year-olds. Some years, it was 7 times as much. So by artificially setting that rate at 3 to 1, they took a ton of cost and moved it onto the youngest section of the population. Also, by the way, the section who had no money, right? We're the lowest income section. And so what you ended up with is a real incentive for people over 50 to stay insured and a built-in disincentive for people under 35 because their rates are about double what they ought to be based on the economics of that risk pool. And so when young people leave, I am never surprised because they're not getting a good deal in most cases. And that was a flaw built into the ACA from the get-go that nobody really had the political capital to correct. Yes, ma'am.
A lot of the questions I had have been answered.
Oh, good.
What
Whew,
remains
that was close.
is, you've described the impact of the ACA on the market, on consumers. What proposals would you have to the current administration and legislatures that could fix the problems that it created? Because it has created a problem for not just the poor, but the middle class to obtain insurance. Even if you can pay your policy, I know people who have health insurance paid by their company, but they cannot afford the out-of-pocket expenses to access the health care that is provided for them. So what recommendations would you make going forward that could change the market for your average consumer?
So the question was, what recommendations do I have to help the health insurance market be more affordable going forward? Okay. Well,
Affordable for insurance.
sure.
You don't
Well,
profit.
Well, you know, the nice thing about working for Blue Cross as a not-for-profit is, you know, as long as we're breaking even or a little better, we're fine. You know, we don't have shareholders out there screaming for their 3-4%. I don't have to acknowledge those voices that are somewhere else. So that's a benefit. It's a huge benefit for us. In reality, when I think about things that would improve the situation, it's important to remember that around 83 to 85% of the premium you're paying every year goes directly to pay for healthcare costs, okay? So the big money of your premium, 83 to 85% in our experience, is only buying health care. So if I can't make healthcare less expensive, if I can't make hospital visits less frequent and less costly, if I can't get drug costs under control. Do you know, when I joined Blue Cross in 2004, drugs were 11% of our spend, 11% of that dollar, that premium dollar. Last year, they were 25% of our spend. So what are drug prices crowding out? Doctors. They're basically crowding docs out with the drugs that they're prescribing. So it's a battle, right? But healthcare costs are the answer. On the overhead side, after you take in 4% or so for ACA taxes, the insurance companies, we run on 10, 11%, pays for everything. Commissions for brokers, all our salaries, everything we do, 10 or 11% runs it. The big savings is on the healthcare side. So hospital avoidance is going to be something you're going to hear us talk about constantly. How do we teach people to be healthier so they don't end up in the hospital? Making sure they're on the correct drugs when they have a long-term condition, the right drug for the right condition at the right price and the right setting. All of those things are important. It's got to be about fixing healthcare costs if we're going to make a meaningful difference in how much premiums cost. There's no other way. There's no way around that.
What will the elimination of the mandate do to this environment?
The elimination of the mandate could have the potential to make the individual marketplace a little more expensive. I don't think it's going to have an impact on the group insurance marketplace very much, but you may see a few more people become uninsured. I personally haven't felt like the mandate has had teeth in a long time. If you take a look online, you can look on healthcare.gov's website. There's a list of the exemptions you can claim if you don't buy insurance every year from the individual mandate, and there are 29 of them. And some of them are just very easy to claim. Most tax guys are aware of this. So last year, for example, 12 million people didn't buy insurance and should have been taxed. After they claimed their exemptions, only about 2 million people paid the tax. So I don't think it has the driving force that we hoped that it would have. Yes, sir.
Go ahead.
Do you think if there was more education, like as a provider, I know that it's a lot more expensive for someone to go to an ER than it is for them to go to a direct provider?
Absolutely.
I feel that is one place that hasn't received enough attention. What could be done to educate the population that you can get a higher level of care if you go into a physician's office or quick care versus going to an ER?
Yeah, I can tell you the question is, how can we educate the populations on the appropriate setting for the care that they need at that point in time? Why does it always have to be the emergency room or urgent care? I can tell you from Blue Cross's perspective, we are huge on making sure people have relationships with primary care docs. We have a lot of products that we're offering to employers now where PCPs are required. You basically have to tell them who your doc is. You have to get a relationship with a PCP, and if there's nobody more qualified in the marketplace to make sure, in our opinion, to make sure that your care is the right setting, the right care at the right time, that needs to be directed by a manager, by a primary care doc who can do that. So anything we can do to drive people to primary care, we do it. It's getting harder and harder. You've seen some insurance carriers take some rather extreme measures when people go to the emergency room for a non-emergency, to the point where they've said in some states, we're just not going to pay for it. We're not there, but we are in a situation where we want to make sure people are clear. If you're having an emergency, you need to go to the emergency room, right? But we want to make sure that people have a relationship with a primary care doc, and maybe they'll make one phone call before they make that move, and that's important. Yes?
For the benefit of economists, you have an economics position is rather prestigious, I would say. Social Security also impacts the young because they pay the same percentage as the old while they're saving for that first down payment of the house, etc.
Yes.
But they manage to do that without a problem, so that is a slope that is not 2% and then grows to 14 and 65. I'd mentioned, and also you mentioned the Medicare Advantage costs are high in terms of expanding to the other population, but you just mentioned it's as much as 6 times as much as somebody younger for their utilization. Somebody 64 versus 21 is an example. But also, not in a vacuum. When this program was presented, the Affordable Care Act program, it should be defended by the economists such as yourself, that there was a chorus of, you don't have to buy health insurance by a continuous group that drowned out, that you don't have to buy health insurance. If you're young, avoid it, don't pay it, we're gonna cancel it, and everything else that we've seen on a political standpoint on a continuum. In fact, the current president even says that basically the Affordable Care Act disappeared.
So what's your question?
I'm defending economists when you say that you missed it, but maybe you didn't miss it. Maybe the economists across the nation did miss it. We had a concerted effort to undermine this particular program. Now,
All right, he's got to go here.
Yeah.
does Blue Cross support the concept of the Affordable Care Act?
We absolutely, Blue Cross, the question is, does Blue Cross support the concept of the Affordable Care Act? The Blue Cross has been a 100% completely dove into the pool, willing participant in the ACA since day one. We believed in the potential. We invested hundreds of millions of dollars in setting up the systems. We hired lots of people because of the compliance burden that it imposed. We embraced the law tightly, and it's been a challenge. It continues to be a challenge.